Welcome to this seminar. My name is Lena Pelander. I'm a veterinarian, a European diplomat in small animal internal medicine. I have a special interest in kidney disease, both when it comes to clinics and research. And I defended my doctoral thesis in 2018, and it concerned diagnosis of chronic kidney disease in dogs. And today I will talk about chronic kidney disease in dogs and cats. And I will talk quite a lot about diagnostics because it's, of course, very important that we get the diagnosis part right before we start to think about what to do with our patients. We will also talk about staging of chronic kidney disease and certain aspects of management of these patients. So there are a few kidney-related definitions and acronyms that have changed or are at least somewhat new, so I thought I'd go through them a bit. Before, we used to talk about chronic renal insufficiency and chronic renal failure, and those terms were quite vague, and they included also mainly the later parts of the clinical course when the organ function is very, very decreased. So the newer term chronic kidney disease comprises the whole spectrum then, from early on to the bitter end. In the beginning, the only problem may be that the kidneys do not look healthy on ultrasound, but the animal doesn't know about it. And then it can still be called kidney disease due to this newer definition that we have. Well, it's not all new, it's like the last 10 years or so, or even 15 maybe. And the definition of CKD is structural or functional abnormalities of one or both kidneys, and it has to have been going on for a duration of at least 3 months. Similarly, AKI, acute kidney injury, is the current way to describe acute insults to the kidney. AKI can heal, and healing may take a long time, and it may take longer than the 3 months that are used to define CKD. And that is why the new term AKD was introduced to describe the time during which the animal is recovering from AKI. So both acute and chronic disease may be categorized according to what compartment of the kidney that is primarily damaged. And that is the glomerular part of the kidney that comes with proteinuria, or the tubulointerstitial disease, and that does not usually come with, at least not a lot of protein in the urine, and the earlier stages of tubulointerstitial disease are the hardest for us to diagnose at an early stage anyway. When it comes to acute kidney injury, the reason for the kidney injury is sometimes, or quite often actually, possible to find out. Common reasons are obstruction, intoxication, ischemia, and infection. We also quite commonly see acute glomerular disease, that is with proteinuria. And the reason that I put that in a different color is that it's often not included when people talk about AKI. In chronic disease, the reason for disease is much more often unknown, even though there are exceptions to that, such as specific hereditary diseases, or that the animal has had earlier episodes of acute kidney injury, for example. Instead of talking about the reason that the animals have CKD, we characterize CKD according to the compartment primarily affected. So we talk about glomerulopathies with proteinuria, or interstitial or tubulointerstitial disease. As I mentioned previously, I think the diagnosis part is very important. A diagnostic investigation always starts with a good history taking and a thorough clinical examination. I cannot stress enough what important that is. It's such an important part of diagnosis, the history and the clinical exam. Test results are then interpreted in the light of the findings at history taking and examination. In addition to blood and urine testing and blood pressure measurements that are shown on the pictures here, diagnostic imaging is also an important part, maybe especially ultrasound. And we also at my hospital use scintigraphy for measurement of the glomerular filtration rate, GFR, that we usually call kidney function. But I will not be talking about diagnostic imaging at all today. So the most traditional kidney-related test is the indirect marker of GFR, glomerular filtration rate, or the kidney function test, creatinine. Creatinine is the classic and also the best marker, I would say. So I will talk mostly about creatinine, but there are also other markers as well. For example, SDMA and also cystatin C measured in serum. And most of the information that I will show in the next couple of slides is true for all circulating GFR markers. So for creatinine, urea, SDMA, cystatin C in the blood. There are also, of course, things that differ between these markers, such as the dependence on muscle mass for creatinine. And that is also what makes it great to have many markers for the same thing, because then you could look at a dog, for example, it has no muscle left. Then creatinine will be falsely low in that dog. Well, then you could look at urea or cystatin C or SDMA. If they are elevated, then creatinine is probably falsely low because the dog simply doesn't have any muscle, because the creatinine comes from the muscle. It's part of muscle metabolism. One problem when we interpret these markers, when we get the test results back from the lab, is that they're not linearly associated with kidney function. So we can see on these graphs here, these are about 100 dogs from my doctoral project, and GFR is on the y-axis, and creatinine or SDMA or cystatin C are on the x-axis. And we can see this curvilinear relationship between these markers. So that means that in early disease, when GFR is declining, these markers won't really show much. They will increase within the reference interval, but it will only be quite late that they will increase above the reference interval. And that is true for all of these markers. So exactly how sensitive you want them to be, that depends on where you put your cutoff to say that this marker is now elevated. If you lower this cutoff, it will be a more sensitive marker. But then you will have problem with false positives, okay, large dogs, for example. So this is the study that the graphs on the previous slide were taken from. And in this study, we aim to compare the newer markers, SDMA and cystatin C, with creatinine, our old friend and marker that we have always used, for diagnosis of decreased kidney function in dogs. So SDMA and creatinine, as molecules, they have the same diagnostic value. If you, as I said, want to find a decreased kidney function early, you lower the cutoff for azotemia. And when you do that, you will get some dogs that have a fake positive. So they will have elevated values without having a decreased GFR. And that is true for all markers. It's also important to think about that SDMA and cystatin C will also be affected by pre- and post-renal factors, just like creatinine. And we will look at that a bit closer, I think, on the next slide. So azotemia means increased urea and creatinine, but we can use the term also for increased SDMA, for example. The same principles apply for every circulating indirect GFR marker. We have to exclude post-renal and pre-renal reasons for increased creatinine or SDMA before concluding that we have a diseased kidney. So if we start with post-renal azotemia, the classical situation is that the animal cannot urinate. So you have some kind of urinary obstruction. If they can urinate, then we probably do not have a post-renal azotemia. There are exceptions to that. However, you can have, for example, blunt trauma to the abdomen with rupture of the urinary tract, uroabdomen. And also, especially in cats, we have to think about urethral obstruction that can sometimes contribute to post-renal azotemia. But most of the time, post-renal is quite easy to rule out with a good history and a clinical examination. If there are difficulties, diagnostic imaging, or if needed, cystoscopy can be of help when trying to find this out. So the next thing to exclude is pre-renal azotemia, pre-renal reasons for these markers to be high. And that means that the kidneys do not get enough blood to filtrate, and therefore the GFR goes down. Dehydration and hypovolemia can be assessed using your history and clinical examination. And you can also use a urine sample to look at the specific gravity. You have to catch this urine before giving any fluids to the animal, though. If you have a dehydrated dog, the urine-specific gravity should be higher than 1035. And in the cat, it should be higher than 1040. If the kidney is healthy and if they're able to perform their job, which is to keep water in the body, not pee it out. You don't want to lose water if you're dehydrated and hypovolemic. So if the kidneys are healthy, you should have a high USG in both species. There are exceptions, like diabetes mellitus, hypercalcemia, Cushing's disease. Then there are molecules interfering with tubular function in the kidney, and maybe then the kidney cannot keep water in the body, although the kidney is healthy. But if those other diseases are excluded, the kidney should be able to save water, and that means a high USG. So in a dehydrated animal, use the USG to evaluate if the kidneys are doing what they can to save water. So finally, if you think neither post-renal nor pre-renal azotemia is present, what you probably have then is renal azotemia. So that is, something is wrong with the kidney itself. Once you are quite certain that the azotemia is renal, you should start thinking about the probable clinical course. The reason for this azotemia, how did it happen during time? This is very clinically relevant, both for management of the patient and for prognosis, what you're going to tell the owner about their animal. The first type of clinical course, shown here, is an acute kidney injury on a patient that was previously healthy. So we have GFR, kidney function, on the y-axis, and time on the x-axis. So from the beginning, the GFR is just fine, and then suddenly something happens, an infection, ischemia, intoxication, all the things we talked about before. And this insult is bad enough for kidney function to decrease. So it has to be a real whammy to the kidneys. From down at the bottom of the red line, things could go a number of ways. The animal could die. After all, about 50% of dogs and cats with really bad AKI, they actually do die, especially if you don't have hemodialysis, which I do not have where I work. Things could also completely reverse and result in normal kidney values for the rest of this animal's life. We could also have a persistent decreased function, so non-progressive CKD, and that's probably not relevant to the patient either. It can go on fine with less than 100% kidney function. And we could also have a situation where the damage was large enough to start this vicious cycle of declining GFR, what we call a progressive CKD that is going to be worse and worse in this vicious cycle. As I mentioned before in one of the first slides, I think the time from the kidney injury to recovery, if the animal recovers, it can take weeks, it can even take 6 months. This can go on then for more than 3 months. And from the definition of CKD, you could say, well, then the animal has CKD. The function has been decreased, it's been more than 3 months, let's call it CKD. But this situation is completely different. This kidney is healing, these kidneys are healing. It's going in the right direction, hopefully. So it's nothing like CKD. So that is why they gave this a new name, acute kidney disease. And of course, even a dog in an acute kidney disease, healing from an AKI, as we said before, it can lead to CKD. But in itself, it is called AKD, as long as we don't really know where it's going. Next graph here is showing chronic kidney disease, CKD. If CKD is progressive, then the function gradually declines, like the black line shown in the graph. In reality, perhaps most often in cats, this decrease in function is rather stepwise, like the red line. And always remember, with the current definition of CKD, that is quite broad, I'll take it again, it's a structural or functional abnormality of one or both kidneys that has been going on for at least 3 months. That's quite a broad definition. Some of these animals that you can put into this definition, they won't have progressive disease. So it's possible also that you have some kind of injury to the kidneys and then you have a decreased function, but it's just not going to change over time, like the dotted red line in this graph. It's a possible option as well. And I'm not sure we should call those animals chronically ill because they will probably never have a problem because of this decreased function, unless they have new insults to the kidney. One definition also that is quite new, at least the short version ACKD came up a couple of years ago. This situation is when an animal that already has a CKD, a progressive disease, and the GFR is slowly going down, gets an acute kidney injury on top of its CKD. Animals with chronic kidney disease are more at risk for acute kidney injury than individuals with normal kidney function are. And the existence of an underlying progressive CKD makes a difference for the prognosis, of course. If you see a patient with AKI, so that would be both blue circles on this slide, it's of a clinical value to try to find out if there is an underlying CKD or not. If you have a patient with AKI, that's all you know right now, it's an AKI. And sometimes this is easy. The kidneys look like raisins on ultrasound, for example, but it can be very difficult to exclude chronic kidney disease in dogs with pretty normal looking kidneys. If they have no evidence of fibrosis that is really shown on ultrasound, it's hard to know. And the presence of hyperphosphatemia, it doesn't help. That occurs in both occasions because phosphate goes up when GFR goes down. Maybe you're thinking about anemia, and yes, anemia is probably more common if the animal has a CKD, but there could be other reasons for an anemia. It could occur together with an AKI. So here we have to use our detective skills and take in all the leads we can get and try to make a whole assessment of the patient in front of us. So let's take an example. If we think about a dog that has a creatinine of 300 micromoles per liter, that is in my Swedish value. I don't know if you use American values, and I'm not sure what it would be, maybe 4 milligrams per deciliter. So what's the prognosis for this animal with 300? Our normal value goes up to maybe 115, so it's clearly acetemic. Well, that will depend on if this is a pre-renal, post-renal, or renal acetemia, of course. But say that it's renal. We know it's a renal acetemia. It's because of a decreased GFR of kidney origin. What is the prognosis for the dog? Well, that depends on if the dog had 100 in creatinine yesterday and 300 today. Then we probably have an acute kidney injury. And these kidneys could heal. However, if 300 is something that the dog has slowly reached over months to years, it's gone from 100 to 110 to 120 and so on up to 300. This situation, 300 is probably going to be the best that this dog will ever have for the rest of its life. So a lot worse prognosis for that dog than the first example. So clinical course is important for evaluation of our patients. Apart from this pre-renal, renal, post-renal, there are a few other things we have to think about when we interpret these markers. Creatinine, as I said, is a metabolite from muscle metabolism, and so it differs among breeds and it differs among individuals with different muscle mass. Greyhounds, for example, are known for their high creatinine. So if you have a cutoff for creatinine in your lab that is aimed at finding a decreased GFR early, chances are that a healthy greyhound is often acetemic in your lab. Smaller breeds have a lower creatinine. So I usually say approximately the lower half of the reference interval for creatinine is probably where most small dogs usually should be. Regarding the small versus large breeds, it seems that smaller breeds actually have higher GFR and therefore a lower creatinine concentration in health. At least according to, for example, this study, where we can see that with a higher body weight, these are dogs in the left graph here, GFR is actually lower. To the right, we have a graph showing different breeds of cats and their creatinine values. These are healthy cats. And we can see that Burmans have higher creatinine concentrations. The other breeds shown in the graph are Abyssinian, Norwegian, forest cats, and Siberian cats. So Burman are a bit special in that regard. So let's also see how creatinine in serum behaves. This is also, it might seem, bear with me here, because it is clinically relevant. To the left, you can see a graph showing the iron concentrations in 5 subjects. In this case, these are 5 Scottish men. That doesn't really matter. It's the same principle for our dogs and cats. These iron concentrations have been measured multiple times over a couple of weeks. So in every man, the iron concentration is somewhere between 3 and 30, and it can change a lot from time to time, but the situation is similar for all 5 men. So the intra-individual variation within one person is higher than the variation between the men. They look very similar in total when you look at iron over a period of a few weeks. In this situation, it's perfect to use a population-based reference interval. Let's just say it's 5 to 30, and most normal, healthy, male Scottish men will fit within here whenever you take this blood sample. In the right figure, however, we can see how the situation is for creatinine. These are still the 5 Scottish men, and they have every single man has a very similar creatinine from time to time here, right? But the variation between individuals is huge. The red arrow that I have put on top of the graph, that could, for example, represent a Burman cat or a greyhound. Then we have to ignore the actual values for creatinine, but that's not relevant here. I just want to show this point. As you can see, using a population-based reference interval from 67 to 130 in this case, that's not going to be as good for creatinine as it was for iron. This is the case for creatinine in small animals as well. What I can add to the last slide also is that this you can look at the animal to see if is it a large breed, is it a small breed dog, does the cat or the dog have a large muscle mass or absolutely no muscle at all. Then you can see that, so you can put that into your evaluation of the creatinine function. Other markers like cystatin C change with a bit with age, and SDMA also changes with some things, but we don't quite know what. And then it's even harder because you can't look at the animal and say, oh, this might have a falsely high SDMA, for example. So while the muscle mass could be looked upon as a problem for creatinine, it's also something that we can actually assess and take into our medical thinking. So here is it written out at last, the definition of CKD. Definitions are important. I actually found that out during my doctoral program, because if you don't have a definition, you can't diagnose a disease mainly. And creatinine is used to diagnose. We have a rather broad definition, like I said. If you have a cyst in one pole of a kidney, it's there for your whole life. You have, by this definition, CKD, but it's not really relevant. So I think we should use progressive CKD. That is what we should call CKD. But there are advantages with using CKD instead of just saying kidney insufficiency or failure, because we can also detect early stages of progressive disease. And if it is progressive and if you find it early, then you can do something for that animal. And we will come to management of the patients soon. Staging of CKD is something that we do in order to be able to talk about our patients in the same way. If I say that I have a stage 2 dog that I'm treating, then I could look into a guideline and see what should I do with a stage 2 dog, for example. It's important to know, though, that staging is performed after diagnosis. So first you diagnose CKD in your cat or in your dog, and then you go to staging. IRIS, International Renal Interest Society, they came up with this staging scheme many years ago, and it's based on the stable creatinine concentration. So that means you should never stage an acutely ill animal coming to your clinic. This staging should be the creatinine concentration that the animal walks around with every day. IRIS has added information about how to use SDMA in the process of staging as well, but creatinine is still the mainstay and the most important marker of GFR. So this is what it looks like for cats. And the cutoffs between different stages of CKD for cats, 140, 250, and 440. I want to be clear that this does not mean that a cat that has a creatinine of 150, say, has CKD because it's over 140. This is a common misconception, a common mistake people do, that they take this cutoff between stage 1 and 2 and use this as a reference interval. That's not the right way to use this. The staging comes into play only after you already have made the diagnosis of CKD. After giving the animal a particular stage of CKD, according to the stable creatinine concentration, we can also substage them. First, let's look at proteinuria. A protein to creatinine ratio above 0.4 for cats and 0.5 for dogs is considered to be proteinuria. And this refers to persistent values. Protein that is leaking from the kidneys. So not pre-renal or post-renal proteinuria, renal proteinuria that is persistent over weeks to months. Pre-renal, you can almost ignore that. It's not very important, but what is very important when evaluating proteinuria is post-renal. That refers to proteins that enter the urine from the lower urinary tract or the genitalia. And again, it needs to be persistence for us to really care about it, and renal. And the magnitude is assessed using the urine protein to creatinine ratio. That is a way of taking away the influence of how much water there is in the urine. There is always small amount of proteins, even in healthy animals, in the urine, but we care when it increases and when it's leaking through the kidneys. So this is a picture to illustrate the different origins of proteinuria. Pre-renal, not so relevant. It can be, but not very often, so we can ignore that. If we use the cystocentesis to take the urine, we can also exclude genital origin. And if we look at the urinary sediment, and that is inactive, that is, we have no pyuria, no elevated levels of white blood cells, and no macroscopic hematuria, so the urine looks yellow, then if that is all fine, we probably have leakage through the kidneys, a renal proteinuria. And that can be further divided into glomerular and tubular proteinuria. Differentiating the two, a glomerular or tubular proteinuria is sometimes difficult, but the easy rule is that if the urine protein to creatinine ratio is higher than 2 to 3, we probably have a glomerular problem. So protein is leaking through the glomerular capillaries. So back to the staging, and the second way of substaging is to measure blood pressure. This is when it becomes a bit more complicated. We consider a systolic blood pressure of less than 140 millimeters of mercury normal, at least in a clinical situation. At home, it's probably even lower often. And then there are quite narrow spans for pre-hypertensive, hypertensive, and severely hypertensive. And that creates a bit of a problem, as you will see shortly, because blood pressure increases with stress. So the guidelines say you should perform at least 5 to 7 measurements with less than 20% variation, and then take a mean value of these 5 to 7 measurements. They also often say that you should measure blood pressure the first thing you do, otherwise you can't do it at that visit. You have to have the animal come back at a later time point. And we didn't really believe in that, so we performed a study. And this study was published in 2021, and we wanted to look at blood pressure measurements performed at different time points. We had the dogs coming in to include them into my PhD project at this time. So the first blood pressure measurement was performed before anything else. We had done nothing to them. They just came in, we performed blood pressure measurements. The second measurement was performed after the clinical examination and blood withdrawal, and the third measurement was performed after abdominal ultrasound and cystocentesis on these dogs, and they were awake while doing this. And the last thing they did was a scintigraphy. So in one of these graphs, you should see that on a group level, there was no difference in systolic blood pressure measurements performed on these 3 occasions. So on a group level, no difference. But if we take out some of the dogs, I think there are 7 dogs on the second graph here, we've plotted the results. And these dogs had quite large differences between time points. Differences up to 40 millimeters of mercury was not unusual. And some dogs could be stressed in the morning and then they got used to everything. So the blood pressure decreased during the visit. And others were rather calm at first and then they were more and more stressed. And some of them were more stressed in the second measurement, as you can see in that graph. So looking at this table, we can see that a difference of 40 millimeters of mercury is huge. And that's a difference that we had with these dogs between 2 different measurements on the same day at the same visit. And that is actually the exact difference between normotensive and severely hypertensive. That's only 40 millimeters of mercury. So some level of caution is recommended when performing and interpreting blood pressure measurements. Another thing that differs between countries and between hospitals is the devices used for measurement of blood pressure. In this study, we also compared 2 different meters and the differences were quite large, actually. Feel free to read it, it's open access. The take-home message from the study that we are now considering when measuring blood pressure at our hospital is that if the systolic pressure is high after having performed the measurements according to all guidelines, we prolong the measurements. And in many animals with stress-induced, also called situational hypertension, the values slowly decrease. And then we get a plateau where they are stable again, but on a lower level. And there we can calculate a new mean value, as shown in this figure. Quite often in animals that start off severely hypertensive because of stress, we can get a normal value in the end, but that can take 45 minutes sometimes. So in conclusion, regarding staging, we aim for stable values of creatinine and SCMA, if you like. The concentrations that the dog or cat walks around with every day. The blood pressure they have on average throughout every day. Be aware of variations within the animal, among animals, and variations between different methods of measurements. So I would like you to take all these cutoffs with a pinch of salt. Now over to the management of dogs and cats with CKD. There is not time enough to be exhaustive here, but I will talk about some general principles and about management of proteinuria. So as for all chronically diseased patients, the interaction with the owner is always important. Different management options are right for different owners. In fact, evidence-based veterinary medicine has 3 legs to stand on, as shown on this picture. High quality research evidence, clinical experience of the veterinarian, and also the owner's expectations and the owner's ability to pay and to cope. For optimal care, create a relation with the owner, provide information so that the owner can give input about what level of care that they want for their animal. to do exactly everything that is possible to do is not the best way forward for every single patient or every owner. So what is the overall goal of our management of these patients with CKD? First, let's think about slowing progression, which is a goal, especially in the earlier stages. This slide shows the function, GFR, on the y-axis again, which is declining in a patient with CKD. Let's say that the time point marked with an X is the time where the patient starts showing clinical signs of failure, kidney failure, such as inaptitude or vomiting. And somewhere in the time before that, they probably became polyuric, polydipsic. But at the X, they are starting to feel their kidneys are failing. If we detect those progressive chronic kidney disease patients early and then start doing what we can to slow progression of this insidious disease, then the point in time where the animal starts feeling sick could be, hopefully, postponed into the future. That means that the time that the animal is feeling well is being made to last longer. That is what we want. We want them to live longer, but we also want them to have a good life while they are living, of course. So slowing of progression, what we just discussed, is one of the main goals of treatment or management of these patients, and that is especially true in stages 2 and 3. And doing this includes to screen them for complications such as proteinuria. That's why it's included in the staging. Hypertension, that is why blood pressure measurements are included in the staging. And if we find complications and treat them, we save the kidneys. Early on in stage 1, and maybe especially for glomerular disease with proteinuria, it may be possible to identify the etiology. Why did they get this kidney disease? Sometimes. If you can find the reason and remove it, that is one very good way of helping the kidneys as well. Unfortunately, the trigger for kidney disease is often hard to identify, even for glomerular disease, even if we look through the whole animal in more than 50% of cases. It says in the books, I would say more than 70% or even more. We don't find anything, even if we look for it. We don't find a reason for the kidney disease. So we have to treat the kidneys as good as we can. And then lastly, towards the later stages, when clinical signs are coming up, the focus becomes more of putting out fires, so to speak, getting the animal to feel as good as possible until the time has come to let things end. So to sum up this a bit, first we need the correct diagnosis. If CKD is diagnosed, a renal diet is indicated and should be given to the animal, if at all possible. A confirmed hypertension should be treated, and so should a massive proteinuria, because it could lead to a nephrotic syndrome if it gets hypoalbuminemia and edema, and that is a very serious situation. However, before initiating treatment of low-grade proteinuria, other than kidney diet, which is not controversial, I'm talking about medication now, then you should inform the owner about pros and cons of medical treatment, especially in cats. We have no evidence to say that medical treatment of proteinuria in cats, and what I mean by that is some kind of blockage of the renin-angiotensin-aldosterone system with ACE inhibitors or angiotensin receptor blockers, may not make a difference when it comes to survival of these cats. In dogs, we have that evidence, and in people, but not really in cats. So what are we treating when we manage a patient with CKD? We cannot treat the actual disease in the kidneys. As I said earlier, we can identify and treat complications that occur, and in some cases, this will decrease direct consequences of the complication. An example could be a retinal detachment from hypertension that the cats can get quite commonly. I have never seen a dog that had a retinal detachment from hypertension yet. Anyway, we treat the hypertension and the retina may even reattach. And also, in doing that, we are probably protecting the kidneys from ongoing damage. That is, probably we're also slowing progression as well. We don't know that for sure, but at least we take care of the acute complications of the complication, hypertension. Other examples, the proteinuria that we talked about, renal secondary hyperparathyroidism, which can in turn lead to mineral and bone disease, that is called now, CKD-MBD, mineral and bone disease. And when it comes to bone disease or renal osteodystrophy, I would like you to take a look at this figure from an article of Shipov and others from 2019. The right part of the figure shows a transverse cross-section of the femoral bone of a healthy cat. The section of a femoral bone on the left-hand side is from a cat with CKD and renal osteodystrophy. And you can note the dramatic increase in resorption, the cavities in this cat with CKD compared to the healthy cat. I can really recommend that publication. Nice pictures and to increase your understanding of this common complication of late-stage CKD. So we talked about renal diet, and that helps with many of these aspects on this slide. So I turn those that renal diet helps with into red picture on these slides. It has been shown to increase survival time, feeding a renal diet in both cats and dogs. It's not entirely known exactly what it is in the diet that's most helpful for the kidneys. And that is probably different for different individuals, I guess. The decreased amount of phosphate helps with the CKD-MBD, and it slows progression probably. The decreased amounts of protein helps with proteinuria, and perhaps also when they are uremic in the later stages. Extra potassium will help the 1/3 of cats that develop hypokalemia with CKD, for example. So there are many things, and renal diets have been evaluated as the whole thing together, the renal diet. So it's and the diet that the cat or dog will eat is a good renal diet for the cat or dog. So diet is the mainstay of treatment in both species. Here are some of the advantages of diet. I listed them. And a common question that I get is, when do we introduce this diet? And I don't think that we have a good answer to that question, actually. It may differ among individuals when they will benefit from a renal diet. Of course, we will have to have a diagnosis of CKD and a clear indication, CKD stages 3 and 4, and persistent renal proteinuria is also a clear indication for renal diet. One important thing when it comes to feeding renal diet, especially in the later stages, is to tell the owners that the most important thing is that they eat their needed calories every day. And it happens that the owners do not want to give them anything else but the renal diet because they have been told so by their vet. But if they can't make them eat enough calories with the renal food, they have to give them something else as well. They should give them as much of the renal food as they can get into them. So 75% renal diet is better than no renal diet. So, but if they don't eat enough, they will waste away and we will lose them. So that is, just try to get them to eat as much renal food as they can, but then give them something else as well if they are losing weight. Renal diet is the way to go, of course, when phosphate restriction is needed. But how do we know that? The answer is that we do not always know. Hyperphosphatemia, that is a clue. And the phosphate concentration in the body is regulated by FGF23, fibroblast growth factor 23. And there is an assay measuring this hormone currently commercially available, but there's not very much evidence regarding if an elevated FGF23 in a cat with a normal phosphate is a reason to start feeding a renal diet. That may well be the case, and that is what some people are recommending now. I think it's reasonable to think so, but I can't say that we know for sure yet. Many people start renal diet when the cats actually become acidemic. Especially in cats, there are some controversies regarding protein malnutrition and hypercalcemia. And regarding proteins, the goal should be to avoid feeding too little protein, and you would know that by the cat losing muscle or dog. Yet not allowing excessive intakes of protein that might risk uremia and increase morbidity. The hypercalcemia risk has been identified in cats given a renal diet very early in the CKD clinical course. And it's probably wise to use an early care type of diet in the early stages of feline CKD in order to not have this hyperkalemia. But if you introduce a renal diet early, perhaps you should keep an eye on calcium for the first time, couple of months or so that the cat is eating. But an early care type diet in the early stage is probably a good thing to do. And remember, body condition score is associated with prognosis. So renal diet for sure, and there are medications to stimulate appetite, of course, as well to use. But if they're not eating enough, they can give other stuff as well, in addition to the renal diet. Speaking of body condition score, if you're not already assessing BCS in animals, I recommend that you start. Charts like these are a good help, but even using these charts, there will be some variation in judgment among different examiners, especially if the 9-point scale is used. There is one 5-point scale and one 9-point scale to be used. So you can look at that a bit more if you're interested. What is, I think, even less used and also slightly more difficult assessment to make is the muscle condition score. But it is important. As mentioned before, it's necessary for a correct interpretation of creatinine concentration, but it's also valuable for patient management to know if the individual has muscle loss. Muscle and fat do not always go together. This rather fat cat in the picture here may have muscle loss, and we cannot know that if we're not examining it. Cats sometimes lose muscle before they lose fat, so it can be unnoticed if you're not focused on the muscle mass while you're doing the examination. So back to the diet a bit more. One of the most important aspects probably is phosphate restriction. In CKD, phosphate is not excreted as it should be, which leads to hyperphosphatemia. And this increases PTH, parathyroid hormone, PTH, is toxic to cells, and we look upon it as one of the uremic toxins. And this renal secondary hyperparathyroidism drives the mineral and bone disease that we talked about and saw evidence of on the earlier slide. And feeding a renal diet will decrease phosphate and PTH and FGF23, all of them. These treatment goals to the right for phosphorus were formulated by experts many years ago, not based on hard evidence, research or so, but they are what we currently have to aim for. It's possible to add phosphate binders to the diet to keep the phosphate down, but first I would advise you to let the diet do its work first. Give it time, give it months. This is not usually an emergency. I will wait many weeks for the diet to fully work first. If you are using phosphate binders and they are calcium containing, keep an eye on the ionized calcium concentration. You do not want to create a hypercalcemia in the patient because that could damage the kidneys. And we don't want to do harm, of course. So we want to do all these good things with the diet. What if they do not eat? Uremic animals can be nauseous, they can vomit, and the vomiting may be triggered by uremic toxins. And we could give antiemetics, like maropitant, for example. What about uremic gastritis? Traditionally, we have thought that dogs and cats get the same kind of lesions that humans do. Edema, ulceration, necrosis, bleeding. Turns out that dogs actually do, but probably less severe lesions than humans. So what about cats? In this study by McLeland and others, 37 cats with CKD and 11 healthy cats were included. And cats with severe CKD had higher gastrin concentration in the blood, as shown in the graph to the left. But what was mainly seen in the stomach, instead of ulceration and inflammation, like in humans and dogs, they saw fibrosis and mineralization. Not one single ulcer in any of these 3 cats. And I once heard Jessica Quimby, the last author of this study, say that after looking at another 60 cats or so, after these 37 cats, still no ulcers. So that is probably not very common in cats with CKD. And on the picture to the right, you can see stomach histology from one healthy cat in the upper left corner and 3 CKD cats with varying amounts of fibrosis in the other 3 corners. Fibrosis turns up blue using this staining. Over to the mineralization that was also seen. It was seen only in cats with moderate and severe azotemia. And this is in contrast to the situation with the fibrosis. The fibrosis was not really associated with the creatinine concentration in the blood. But the fibrosis was only seen in the CKD cats. The mineralization can be seen it's shown in brown color in this figure here. On the upper left corner is a healthy cat, and then the other 3 are cats in different stages of CKD. The calcium phosphorus product was associated with CKD stage. So that means the calcium and phosphate concentrations increase with CKD stage. And this is probably metastatic calcification that primarily affect tissues that secrete acids, such as the kidneys and the gastric mucosa. So instead of talking about uremic gastritis in cats, we should call it uremic gastropathy, really. And therefore also, again, clinically relevant to us, the traditional gastroprotection measures, sucralfate and proton pump inhibitors and such, probably most often not indicated in CKD cats. I usually give them antiemetics and appetite stimulants. And Jessica Quimby has published a number of studies on these treatments in cats, and this is one of them. Feeding tubes, often used in the US, not that much in Sweden, at least not for end-stage CKD, for ethical reasons. For dogs, there is a new substance available, at least in Sweden and in the US, capromorelin. It's an appetite stimulant that is very effective in dogs, but at least in Sweden, at the time, it's quite costly for the owners. In the last couple of slides, I will address management of proteinuria and hypertension. And when I say proteinuria, what I always mean is renal persistent proteinuria. Renal diet is the #1 treatment, and sometimes that will be enough. When it is not enough and you haven't reached your treatment goals, there are medications to use. But before you go to the medications, think about a few things. The magnitude, for example. Are the values close to the cutoffs when treatment is said to be indicated? Think about individual variation, the biological variation over time. Think about differences between methods. Also, cat owners, are they willing to give daily medication to their cats for the rest of their lives, even if they are informed that there is actually no evidence to say that it makes a difference for survival time? Informing owners about things like that, that is practicing evidence-based medicine. And evidence-based medicine is really what we should be practicing, if possible. This is a very famous figure from Hattie Syme's publication in 2006. It's often shown in conferences and congresses. It shows survival time on the x-axis and proportion of cats surviving on the x-axis. And we can see that cats with proteinuria, either borderline over 0.2, or those with a UPC over 0.4, shown by these dotted lines, these cats did not live as long as the non-proteinuria cats, shown by the solid line. So here we can see that proteinuria seems to have a negative prognostic value, and that is true for dogs as well. But that does not automatically mean that giving medication to these cats will change anything. Proteinuria may not be a mediator as much as a marker of more progressive CKD. In people and in dogs, it's been shown in studies that it helps for survival, and we're waiting for a study to show that in cats. If that is the case for cats, we don't know that yet. They have different kinds of proteinuria. They have mainly tubular proteinuria, probably, and the dogs have glomerular proteinuria. And maybe that is what makes a difference between species here. So this is where the information to the owner becomes important. Do we have a patient where we believe that the cat or dog will benefit from medical treatment? Do we have the right owner for it? The owner is not going to notice a difference when you put them on these medications, unless it is a dog with massive proteinuria and nephrotic syndrome, then there is no question about it. But if not, if there is more of a mild proteinuria and you're aiming to decrease progression of kidney disease, they have to be on board on what we are expecting, because you will take them back and look at the UPC again, and it's going to cost money, and they're not going to know unless you really inform them why they should take this medication. And this kind of medication that I'm talking about, RAS blockage of the renal angiotensin aldosterone system, that is part of the unspecific treatment of proteinuria. We can speak about the unspecific treatment and a more specific treatment if we have a glomerulonephritis, that we try to make a difference in the actual glomerulus. But The best way to, or one of the good ways of trying to help kidneys with a glomerulonephritis is to find a trigger, like we talked about before. Take it away or treat it. This includes searching for neoplastic, inflammatory, or infectious disease elsewhere in the body, using blood tests and imaging. And it's hard to find triggers, as I said before. Renal diet is part of the unspecific treatment. Inhibition of the RAS system. Absolute contraindication to RAS blockade is an unstable patient. They should not be hydrated or hypovolemic. The patient needs to be hemodynamically stable before giving them an ACE inhibitor or an angiotensin receptor blocker. They should also not be in acute kidney failure. You should have a stable patient in front of you when you prescribe this. Also, late-stage disease, stage 3 and 4 CKD. For these patients, the risks are much higher than the hoped benefit. And the third part of the unspecific treatment is the thromboprophylaxis. And we use either aspirin in a low dose, 1 to 5 milligrams per kilogram body weight, or clopidogrel. These patients are prone to thrombosis, and we try to prevent that using some kind of thromboprophylaxis. The goal is to reduce urine protein to creatinine ratio. We want the proteinuria to disappear, of course, best case scenario, but a minimum 50% reduction. In order to know what's happening during medication, we have to know where we are before starting treatment. With the biological variation of the UPC being quite large, then maybe it's a good thing to have repeated measurements or the use of pooled samples. You can take 1 milliliter of each of 3 different urine samples. That could help with the quantification of proteinuria before starting treatment. And way down on the slide, as you can see, a 35 to 50% change in UPC is needed before we can say that this is a response to treatment rather than just happening because of the huge day-to-day variation. A UPC going from, for example, 10 to 8 does not necessarily indicate a response to treatment because of this variation. So keep that in mind while interpreting your results. Also, do not forget to look at sediments when interpreting the UPC, because especially pyuria, white blood cells in the urine, can affect UPC. Sometimes a lot, sometimes not so much, but it's hard to know if you have many white blood cells in the urine. And we have the specific treatment. So that is what we use when we think that we have a glomerulonephritis. So we mean an immunosuppressive anti-inflammatory therapy. And it's recommended for dogs with severe, persistent, or progressive glomerular disease. And in guidelines, they say you should have a kidney biopsy. In real life, usually we do not have a kidney biopsy. It's not always possible, especially when the glomerular disease is acute. Biopsy is just not an option. These patients are sick. But in more stable dogs, usually, it can happen to cats as well, glomerular disease, but it's more often the case in dogs. If you have a dog and the unspecific treatment of proteinuria is not doing the trick, a biopsy is recommended. The main clinical question is there evidence of active immune-mediated pathology? The alternative is to try and treat for it during maybe 8 weeks. If there is if it's not working after 8 weeks, you should take it away again. And mycophenolate has been used most often, but there's not a lot of evidence regarding what type of medication to use in different glomerular diseases. For mycophenolate, gastrointestinal adverse effects like anorexia, vomiting, diarrhea are reported most often, but it will usually go away when stopping treatment or reducing the dose. And neither biopsy nor immunosuppression should be undertaken if there are contraindications. Uncontrolled hypertension, coagulopathy, late-stage CKD, and pyelonephritis are examples of contraindications to perform a kidney biopsy. And the EM on the slide there is electron microscopy, which will be performed if you send your biopsy to a renal pathology service, which you really should do. If you do take a biopsy, send it to the right pathology lab. Lastly, the goals of hypertension treatment. It is to prevent damage to target organs. Target organs for increased blood pressure that are most often damaged are the eyes, the brain, the heart, and the kidneys themselves. In a cat with retinal detachment, like I said before, the retinas can potentially reattach if antihypertensive treatment and rest is applied. But we think that by treating hypertension, this is also probably a way of slowing progression of CKD. That is not definitely proven. On this slide, just doses for different medical products or medical ACE inhibitors and angiotensin receptor blockers are shown. The telmisartan dose in dogs is not very evidence-based, but these are the recommendations. I would say that amlodipine is the first choice for severe hypertension in both cats and dogs. If the hypertension is mild, some kind of RAS inhibition can be tried first, especially if there is also proteinuria, because then you can treat both conditions with the same pill. However, remember the contraindications of RAS inhibition. Do not give them to dehydrated, hypovolemic, or AKI patients. That is important. So that was all that I had to talk about today. And these are the things that I would really like you to remember about azotemia. And this applies to, for example, SDMA as well. Pre-renal, renal, post-renal, acute, chronic, or both. What do we have? What clinical course do we have? Look at specific gravity of the urine. Sample urine early before any fluids are given, so you can use a high specific gravity to lean against for thinking azotemia is pre-renal. Similar thoughts should go through your head when you're interpreting a proteinuria in a patient. Especially post-renal proteinuria should be excluded before you start thinking renal proteinuria. Make sure you're treating the right patient with the right owners and not just treating automatically after one urine sample because the guidelines said so. Remember to make a diagnosis first and then think about staging. If you have a stable animal in front of you, at least 2 creatinine values, some time apart is recommended. And different stages of CKD mean slightly different focus, but a renal diet should be given to most patients. For cats in early stages, keep an eye on calcium, keep an eye on the muscle mass to avoid protein malnutrition. And I already mentioned that thought process regarding choosing patients for medical treatment wisely, so I won't repeat that again. Thank you so much for listening, and good luck with all your CKD patients out there. Here is my email address for any questions or comments that you may have. You're very welcome to write to me. Thank you. Bye.